Welcome to this episode of Crit Care Bites, where we'll be discussing setting PEEP, otherwise known as positive end expiratory pressure, in acute respiratory distress syndrome. We'll be covering the physiology of PEEP, different methods of setting and titrating PEEP, a quick review of the 2023 ESICM ARDS guidelines and its word on PEEP, as well as a practical approach. ARDS is a clinical syndrome characterized by lung inflammation, leading to increased pulmonary vascular and alveolar epithelial permeability, which ultimately causes some alveoli to be fluid-filled, some to be atelectatic because of increased lung weight, and some to remain normally aerated. So this gives rise to the functional baby lung concept espoused by Luciano Gattinoni that suggests that the ARDS lung is not stiff, but instead small, as seen in the above diagrammatic depiction. As such, when subjected to the injurious forces of ventilator-induced lung injury, these are distributed over a much smaller region compared to a healthy lung. When it comes to ventilating patients with ARDS, the tenets of lung protective ventilation entail low tidal volumes of 6 to 8 mL per kg predicted body weight, limiting plateau pressures to less than 30 cm water, and the use of some positive end expiratory pressure. Despite years of research, the amount of PEEP and how to set PEEP remains a topic of marked controversy. So how does PEEP help in ARDS? While our first introduction to PEEP was probably oxygenation focused, this is now largely considered as secondary to the lung protective goals of PEEP determination. PEEP is purported to aid in lung protection in two main ways. Firstly, through lung recruitment, the opening up of collapse of fluid-filled alveoli which augments the size of the baby lung, allowing ventilator-induced strain to be distributed across more lung units. And secondly, through the prevention of the cyclical opening and closing of alveoli during tidal ventilation, preventing what has been described as atelectic trauma. Oxygenation improvement is achieved also through alveolar recruitment, which reduces intrapulmonary shunting. Despite an understanding of the physiology of PEEP, one of the key challenges faced clinically is the heterogeneity in treatment effect, which has been largely attributed to the wide variability in the potential for lung recruitability, i.e. the potential for opening up areas of lungs that have become collapsed. Shown on this slide are CT images of two different ARDS lungs at different levels of PEEP, taken from Luciano Gattinoni's 2006 NEJM publication. Figure B at the top shows a minimally recruitable lung where there is minimal improvement in aeration with PEEP increment, while Figure C at the bottom demonstrates a high percentage of lung recruitability. Especially during the COVID-19 pandemic, there have been efforts at phenotyping ARDS to predict recruitability response to PEEP. However, despite numerous methods developed to attempt to characterize recruitability, they are all faced with different limitations, and hence clinical application of these techniques is both varied and limited. The methods of recruitability assessment can be largely classified into oxygenation response, changes in lung mechanics, and those that attempt to quantify the increase in recruited lung volume at higher PEEP levels. Oxygenation response, while most direct, suffers from a lack of attention to lung protection. Most of the lung mechanics-based methods aim to optimize lung compliance based on the premise that compliance improves with successful recruitment and therefore worsens when over-distension of existing aerated lung units take place. Methods based on lung mechanics can only be done in patients who are passive on the ventilator with deep sedation or even neuromuscular blockade. The two main limitations of these methods are, firstly, lung recruitment and over-distension occur in a continuum and can occur simultaneously because of the heterogeneity in the state of the alveolar units. What is measured in these techniques provides an aggregated value of sorts, and while pursuing an optimal value of compliance may be attractive, injurious over-distension is not precluded even at this point. Secondly, the cyclical opening and collapse of lung units with tidal insufflation itself might cause an increase in measured tidal compliance not related to PEEP-induced end expiratory recruitment. In other words, lung mechanics remains an imperfect surrogate for assessment of actual recruitment. Volumetric measurements arguably aim to more directly quantify actual recruited lung volume. However, based on the different methods, limitations include logistical feasibility, like with CT scans, measure inaccuracies and differentiation between volumes accrued to recruited lung volume versus volume from over-distended lung units. Beyond the challenges of predicting recruitability and ultimately balancing the effects of recruitment alongside over-distension, there are a few other important considerations when it comes to setting PEEP. Firstly, from a hemodynamic standpoint, positive pressure ventilation in general works against the right and works in favor of the left heart. Positive pressure ventilation increases intrathoracic pressure, leading to a reduction in venous return to the right atrium. Concurrently, high levels of positive pressure ventilation also leads to compression of intra-alveolar blood vessels, contributing to a rise in pulmonary vascular resistance, as seen in this second image here. In the context of ARDS, over-distension from overzealous PEEP is a risk factor for acute cor pulmonale. Hence, attention should be paid to the RV function in particular. On the other hand, PEEP is often very effective in assisting patients with left ventricular dysfunction, both by reducing the LV preload and a reduction in the LV afterload through a reduction in the left ventricular transmural pressure. Volume status of the patient also affects PEEP tolerability from a hemodynamic standpoint. Secondly, over-distension of the lungs can worsen ventilation through increasing alveolar dead space by converting more lung units in West Zone 1, as seen here, where alveolar pressure exceeds both the pulmonary arterial and venous pressures. Hence, attention should also be paid to ventilation adequacy. Another important concept to highlight when it comes to PEEP is that of transpulmonary pressure, which is the distending pressure the alveolar units are actually subjected to, i.e. the difference between the airway opening pressure and the pleural pressure. It is important to bear in mind that while we often look to plateau pressure as a means of assessing lung compliance and to limit barotrauma, this measurement is reflective of the entire respiratory system, factoring in both alveolar pressure and pleural pressure, when what we are ultimately interested in is the distending pressures across the alveoli. This becomes especially important when there is an elevated pleural pressure from disorders like morbid obesity, abdominal compartment syndrome, or even circumferential burns. This will be discussed in detail later when we talk about the use of esophageal balloons and transpulmonary pressure in PEEP titration. And finally, the polycompartmental theory shown on the right here is described in abdominal compartment syndrome, and it shows how distending pressures from positive pressure ventilation can be transmitted into both the intracranial and abdominal compartments. Hence, paying attention to PEEP in these clinical situations is imperative. To sum things up, what might we consider an ideal PEEP to be? An ideal PEEP should be one that renders lung protection by recruiting collapsed alveolar lung units to augment the baby lung without causing too much injurious over-distension, and also be set at a level that prevents tidal collapse of as many lung units as possible to avert atelectic trauma. When thinking about oxygenation, I find it helpful in thinking about the overall oxygen delivery, hence paying attention to not just my oxygen saturations, but also my cardiac function, both from a right ventricular and left ventricular standpoint. And finally, thinking through specific clinical scenarios that may require some fine-tuning of PEEP, like in obesity, abdominal compartment syndrome, brain injury, and even in dynamic hyperinflation, where PEEP can be used to overcome the requirements for triggering the ventilator. With these considerations, we will now go through some of the different methods to set PEEP, focusing on the context of ARDS. Some of these methods of titration will be discussed, are seen in this slide. We'll be talking about the PEEP FiO2 table, recruitment maneuvers, compliance and driving pressure, the pressure volume curve, stress index, using esophageal pressures to guide transpulmonary pressures, recruitment inflation ratio, and different volumetric indices. We first begin with the PEEP FiO2 table, which couples PEEP to the level of FiO2. The lower PEEP FiO2 table finds its origins in the landmark ARDSnet ARMA trial in 2000, which showed the benefit of low tidal volumes and limitation of plateau pressures in ARDS. The higher PEEP FiO2 was used as a comparator in the alveoli trial. These tables assume that PEEP requirement increases alongside disease severity and to a large extent has remained a reference standard for comparison of other PEEP determination methods. While the paradigm thinking of PEEP has moved beyond purely oxygenation-centric goals, and studies have demonstrated different PEEP responses in patients with similar degrees of hypoxemia, PEEP FiO2 tables still remain a reasonable guide in most clinical situations, and in fact, robust evidence of clinical superiority of other more sophisticated methods is very much lacking. A slew of studies ensued to compare higher versus lower PEEP strategies in different ways. Shown on this slide are three often cited landmark trials, namely the alveoli, the LOFS, and the EXPRESS studies, which generally did not demonstrate mortality benefit but provided suggestion of improved oxygenation with higher PEEP levels. A systematic review and meta-analysis on this topic, published in JAMA in 2010, showed overall absence of mortality difference between higher versus lower PEEP strategies. However, there was a signal of improved survival amongst patients with more severe disease with PF ratios of less than 200, suggesting the need for PEEP individualization stratified by disease severity. Taking things beyond just a higher PEEP, lung recruitment maneuvers such as the 40-40 method and staircase recruitment methods push the boundaries of alveolar recruitment with a temporary use of supraphysiological pressures. They were based on the premise of lung hysteresis, where a higher pressure is needed to open up a collapsed lung unit than to keep it open, primarily because of surface tension considerations. As such, these methods used high sustained pressures to induce recruitment before being brought down to maintain opening. Recruitment maneuvers, however, fell out of favor following the publication of the 2017 ART trial in JAMA, where lung recruitment with titrated PEEP was associated with higher mortality, pneumothorax, and barotrauma. Of note, the initial trial protocol used PEEP levels of up to 45 with driving pressures of 15 cm water. As previously discussed, compliance of the lung increases when new lung units are recruited because the delivered pressure is distributed over more lung units. As such, a method to set PEEP is based on the change in compliance, i.e., if compliance increases when PEEP increases, it suggests recruitment, and when it decreases, it suggests possible overdistension. The concept of driving pressure can actually be thought of as the flip side of the same coin when we look at the mathematical formula of static lung compliance, where it is derived as the change in volume over driving pressure. This concept was popularized by Marcelo Amato in his 2015 landmark NEJM publication, which showed that driving pressure was strongly associated with mortality based on mediation analysis of many of the landmark ARDS studies. A cutoff of approximately 15 cm water has been identified as a threshold for increased risk of mortality based on the chart shown on this slide. One of the attractions of driving pressure is its ease of calculation, which is the difference between plateau pressure and PEEP, and conceptually it represents tidal volume normalized to lung compliance of the baby lung. The way driving pressure can be used for PEEP titration is similar to that of compliance, and by the first equation, it is apparent that improvement in compliance will lead to a fall in driving pressure and vice versa. As previously alluded to, critiques of this compliance and driving pressure methods contend that cyclic opening and collapse of lung units during tidal insufflation may cause changes in tidal compliance not related to recruitment, confounding the reliability of such a method. Nonetheless, it remains a fairly easy tool to use at the bedside and could provide some degree of safety netting in our overall ventilation strategization. Meanwhile, we await results from the DRIVE RCT to validate the use of driving pressure as a means of setting PEEP. Pressure volume curves are essentially a graphical representation of change in lung compliance over the inspiratory and expiratory limbs. These are obtained with patients in volume control set to a constant flow when patients are deeply sedated and passive on the ventilator. Using the inspiratory limb, the lower inflection point that is shown here is deemed as the point of minimum pressure required for alveolar recruitment. Hence, it is recommended that PEEP be set slightly higher above this point. Criticisms of this method include the need for deep sedation and sometimes even paralysis to obtain an interpretable pressure-volume curve. It is also often in practice difficult to identify the lower inflection point of the curve, and studies have shown marked inter-reader variability in identification of these points. Furthermore, as recruitment still occurs above the lower inflection point where the ideal PEEP should be remains uncertain. With a constant inspiratory flow, i.e. using a square waveform in volume control, the shape of the airway pressure-time relationship reflects changes in compliance during inspiration. The stress index is a coefficient that describes the rate of change in the slope of the pressure-time curve during tidal inspiration. A value of more than 1, as shown here on the right, where the slope increases, suggests less compliant states and overdistension. When the levels are less than 1, and it shows a decreasing curve or a convex curve, this suggests increased compliance and potential for recruitment with additional PEEP. Hence, the aim is to set PEEP to a stress index as close to 1 as possible, where the slope of the pressure-time relationship changes minimally during inspiration, corresponding to a balanced point of adequate recruitment and minimal overdistension. A 2007 publication by Grasso and colleagues compared PEEP adjusted based on stress index versus lower PEEP FiO2 table found that a lower PEEP was used using the stress index method, and this was associated with better respiratory compliance, lower concentration of inflammatory mediators, lower PaCO2, and similar arterial oxygenation. However, studies demonstrating improvement in clinical outcomes is lacking. Moving on to esophageal manometry and transpulmonary pressures. Transpulmonary pressure is defined as a net distending pressure applied to the lung and mathematically derived as the difference between plateau pressure and the intrapleural pressure that is surrogated by esophageal pressure. The main rationale of transpulmonary pressure is that it takes away the effect of the chest wall compliance on the respiratory mechanics, isolating the pressures that actually affect the lung and alveolar units. This is deemed particularly useful in conditions like morbid obesity, kyphoscoliosis, and abdominal compartment syndrome. The way transpulmonary pressure is used in PEEP titration is twofold. Firstly, by limiting inspiratory transpulmonary pressures to less than 25 cm water. This is conceptually similar to how we limit plateau pressure to less than 30 based on the AMA trial. But in the event that the plateau pressure is more than 30, but transpulmonary pressures remains less than 25, this suggests that there is a significant contribution of pressure by the chest wall, and the higher plateau pressure is probably acceptable. On the expiratory side, the idea is to keep expiratory transpulmonary pressure out of the negative range because this will suggest predisposition to alveolar collapse. Hence, adjusting PEEP to inspiratory and expiratory transpulmonary pressure in the stated ranges limits distending pressures and minimizes alveolar collapse during tidal ventilation. Although conceptually attractive, this method suffers on the grounds of practicality. Firstly, esophageal manometries are not routinely available in most ICUs. Secondly, the readings that are measured are prone to error either from positional, postural, or inflation-related considerations. Moreover, there is some controversy on the best method for using esophageal pressure to calculate intrapleural pressure. For example, whether there's a need for a correction factor and looking at tidal changes in esophageal pressures. From an evidence-based standpoint, the two EP-VEN studies did not show definite clinical benefit of esophageal pressure-guided PEEP titration. The first publication by Daniel Talmor in NEJM 2008 looked at 61 patients with ARDS undergoing PEEP titration based on the lower PEEP FiO2 table versus esophageal pressure-guided titration. While the study suggested improved PF ratios and improvement in the respiratory system compliance, it was not adequately powered to assess clinical outcomes. The larger EP-VEN2 study that looked at 200 patients with ARDS actually compared esophageal pressure-guided PEEP titration to the higher PEEP FiO2 table and did not show any difference in the rank composite scores incorporating death and days free from mechanical ventilation. As such, esophageal pressure-guided PEEP titration remains largely confined to the space of clinical research work and will likely only become translational when backed by evidence of clinical improvement. The recruitment inflation ratio is a fairly recent method developed by Laurent Bouchard and Lu Chen that provides a bedside method to assess recruitability on volumetric grounds using the ventilator. Essentially, a patient is transited from being ventilated at a higher PEEP of 15 cm water to a lower PEEP of 5 cm water, during which the increase in expired tidal volume is compared to the volume predicted by compliance at a low PEEP, wherein the difference is estimated to be the recruited volume. Using this parameter and some fairly complicated mathematics, a value called the recruitment inflation ratio, which represents the compliance of the recruited lung to that of the respiratory system, is derived. Values of more than 0.5 suggest potential for lung recruitment, where it is suggested that higher PEEP levels can be used, and if it is less than 0.5, lower PEEP levels can be used instead. The calculations can be done quite easily through the RT-Maven website as shown in this slide, with the instructions of the maneuver shown here on the right. Finally, a variety of imaging-based methods of assessing lung recruitment at different PEEP levels have been studied. CT scan, electrical impedance tomography, and ultrasound modalities are such examples. Arguably, these imaging methods may provide more direct means of measuring actual recruited lung volume compared to lung mechanics-based measures. Regardless, limitations still exist for each of these modalities. Some methods like CT-based approaches are logistically impractical and are hence confined to the realms of research. Tools like EIT and ultrasound may prove to be more feasible. However, we await more clinical studies to determine actual benefits. The 2023 ESICM guidelines provide the following recommendations. In terms of higher versus lower PEEP, it does not actually state a particular recommendation, and whether or not a respiratory mechanic-based strategy should be used remains uncertain. It, however, recommends against the use of prolonged high-pressure recruitment maneuvers based on the concerns raised by the ART trial of potentially increased mortality and barrel trauma, and it also suggests against routine use of brief high-pressure recruitment maneuvers. Putting everything together, I think firstly it is important to stratify patients based on the degree of respiratory failure, where patients with more severe disease could potentially benefit from more careful and intricate PEEP titration and determination. Assessment for PEEP-sensitive comorbidities like RV and LV failure, obesity, abdominal hypertension, raised intracranial pressures, and even dynamic hyperinflation is important. The lower PEEP FiO2 table can be used as a starting point and can be further refined by other methods such as driving pressure or recruitment inflation ratio as discussed. And attention should also be paid to hemodynamics, ventilation, and global oxygen delivery, apart from just oxygenation and lung mechanics. And ultimately, aiming for lung protection through recruitment and prevention of alveolar collapse, adequate gas exchange from both an oxygenation and ventilation standpoint, and stable hemodynamics. Hence, it is important to remember that the effects of PEEP are multifactorial, and it is important not to just look at a single parameter, but all these various important endpoints as well. In summary, the concept of the baby lung, where there is disease heterogeneity and different compartmental pressures, is important in ARDS. PEEP is a double-edged sword. It can be both advantageous and disadvantageous in terms of gas exchange, lung protection, and hemodynamics. PEEP is not just about oxygenation, but it's also integral in a lung protective strategy where it aims to reduce inhomogeneity, improves distribution of strain, and prevents atelectic trauma. Various methods to assess recruitability has its own strengths and limitations. Available bedside options include the PEEP FiO2 table, driving pressure, and the recruitment inflation ratio, as well as other methods that can be based off the ventilator, such as using pressure volume loops. Importantly, marked heterogeneity across patients, and even for the same patient across different time points, should be recognized, and PEEP should always be constantly individualized. And currently, clinical evidence is limited in this space, and there are multiple ongoing trials. So this slide shows some podcasts and some YouTube videos that I've actually found fairly helpful in the review of this topic, and these are resources that you could consider looking at. And these are some of the references of some of the key important studies and review articles that were used in the preparation of this presentation. I hope that you found it useful. Thank you very much.